This module is one in a series of modules for guideline development and the GRADE approach. In this module, I will provide an overview of the GRADE evidence profile and how it is used by guideline developers. We introduced in the previous video an overview of the GRADE approach in guideline development. In this video, we will focus on the top portion of the diagram and how we present the summary of the evidence for a specific healthcare question using the evidence profile. The summary of the evidence in the form of an evidence profile is a key milestone on the path to a recommendation. When making recommendations, a guideline panel will need to consider the evidence. This can be difficult when panel members have not agreed on which evidence to consider and how good that evidence is, making it difficult for the panel to compare the benefits and harms of an intervention option. In our work with guideline panels, we have found that presenting the evidence in a table facilitates the decision-making process. We refer to this table as an evidence profile. A guideline panel should base its recommendations on the best available evidence related to the healthcare question and should seek and consider the evidence relating to all patient-important outcomes. The evidence profile is developed using the best available synthesized evidence, ideally from an up-to-date, high-quality systematic review, which can be an existing systematic review or one that is conducted by the guideline development group. Some systematic reviews, such as Cochrane reviews, already include evidence profiles in the publication. The evidence profile is a method for presenting information about the available body of evidence, the quality of that evidence, the judgments that bear on the quality rating, and the effects of the alternative management strategies or interventions on the patient-important outcomes of interest. This is a typical format for an evidence profile. Note that the format of the evidence profile may vary slightly for different types of healthcare questions, such as questions about diagnostic tests, but the key features remain. One evidence profile is created for each healthcare question that will be addressed in the guideline. The question is presented in the PICO format, describing the population, intervention, comparison, and outcomes. The patient-important outcomes relevant to the healthcare question are presented by row. The outcomes represent the potential benefits as well as the potential harms of the intervention options or management strategies being compared. The two sections organized in the columns of the table are the quality of evidence assessment and the summary of findings for each of the included outcomes. Below the table are footnotes, which provide explanations about information in the table, such as elaboration on the judgments made for the quality of evidence assessment. Reading the footnotes is important for understanding all the information in the table. Let's now go through the specific example to show how the evidence profile is used in guideline development. Here we have a healthcare question about using or not using hip protectors for frail elderly in long-term care facilities to prevent hip fractures. Hip protectors are specially padded undergarments which may protect the hip when someone falls. The guideline panel wanted to know whether to recommend frail elderly in the long-term care facilities to wear hip protectors. This is the evidence profile that was prepared for the healthcare question. In this case, we conducted a systematic review of the effects of hip protectors on hip fractures, pelvic fractures, quality of life, and mortality, all considered patient-important outcomes. Let's take a closer look at the hip fracture outcome. This is an example of a dichotomous outcome, in other words, one that is evaluated as present or absent, or yes or no. There were 5 randomized controlled trials that evaluated the impact of hip protectors on hip fractures in a total sample of 1,426 older people living in institutional residences. The methodologists evaluated the quality of this body of evidence by assessing the 5 factors considered in the GRADE approach: the risk of bias, or study limitations, inconsistency of the evidence, whether studies show similar effects, indirectness of evidence, whether the patients and interventions in the studies are similar to those who we are making recommendations for, imprecision, how wide the confidence intervals around the estimates of effects are indicate how precise they are, and publication bias, whether certain studies, particularly those showing a negative or no effect for an intervention, are missing from the literature. Concerns about each of these factors are noted in the evidence profile as serious, very serious, or none. We will not go into the specific details of how to rate the quality of evidence in this video, but note in this example that there was a serious concern about the risk of bias in the trials, as well as imprecision in the effect estimate. Looking down at the footnotes, we see that there was a lack of blinding of participants, investigators, and outcome assessors, and large loss to follow-up across the trials. There were also few events and wide confidence intervals that included both harm and benefit. For these two reasons, the overall quality of the evidence for the hip fracture outcome was downgraded by 2 levels from high to low. Now taking a look at the summary of findings sections of the table, these two columns report the total number of events in the control group, those randomized to not use a hip protector, and in the intervention group, those randomized to use a hip protector, summed across the 5 studies. The next column provides the pooled relative effect, which here is reported as the relative risk. In this example, because the relative risk is less than 1, it favors the intervention, meaning that the event or hip fracture is less likely to occur in the intervention group than in the control group. Note, however, the wide confidence interval that includes both appreciable benefit and appreciable harm from hip protectors for the hip fracture outcome. For dichotomous outcomes, we have found that it can be challenging to use the numbers typically presented in research studies, such as relative risks and odds ratios, so the numerical findings are also presented as an absolute effect. The absolute effect shows the difference in risk between the two groups and shows how many fewer or more events occur in the intervention group as compared to the control group. In this table, the absolute effect shows what would happen in 1,000 people who wore hip protectors and what would be the benefit or harm with respect to hip fractures as compared to 1,000 people who did not wear hip protectors. Here we see that in a population where the baseline risk, or the control group risk, is 60 hip fractures per 1,000 people who did not wear hip protectors. There will be 10 fewer people per 1,000 who have a hip fracture if wearing a hip protector. Note again the wide confidence interval for the absolute effect. In order to evaluate the absolute effects, a guideline panel will need to consider the baseline risk and whether it is representative of the population for whom they will be making a recommendation in their healthcare setting. During the development of a guideline, the methodologist will search the literature to obtain information about the baseline risk that is representative of the population to which recommendations will apply, which can typically come from large observational studies and systematic reviews. We report the absolute effects for all outcomes, which makes it easier for guideline panels to compare numbers across outcomes. The evidence profile can also present continuous outcomes, in other words, outcomes that are measured on a numerical scale. In this example, quality of life is measured as a continuous outcome using a scale. Continuous outcomes are typically summarized as means, and the effect is presented as a mean difference, which is the difference in means between the intervention group and the control group. A mean difference of 0 would indicate no difference between the comparison groups. For this outcome, there was one RCT with 235 participants. The mean quality of life in the control group, those randomized to not wear a hip protector, ranged from 0.7 to 0.75 on a scale of 0 to 1. The mean difference was 0.13, lower on the 0 to 1 scale for the intervention group, indicating a lower quality of life estimate for those wearing hip protectors. Altogether, guideline panel members use the evidence profile to evaluate across all the relevant patient-important outcomes the size of the desirable effects or the anticipated benefits of the intervention, as well as the size of the undesirable effects or the anticipated harms of the intervention, to decide whether the balance between the desirable and undesirable effects favors the intervention option or the control. Using the evidence profile, guideline panels are also presented information about the quality of evidence for each outcome. For guideline developers, the quality of evidence reflects the extent to which our confidence in an estimate of the effect is adequate to support a particular recommendation. In this particular example, the panel evaluated the moderate size of the desirable effects, including the reduction in hip fractures and mortality, and the small size of the undesirable effects, including an increase in pelvic fractures and the reduction in quality of life, and concluded that the balance between the desirable effects probably favors using hip protectors. It is important to note that the information on patient-important outcomes presented in the evidence profile is not the only information considered when formulating a recommendation. Additional information such as patients' values and preferences towards a certain outcome or intervention option as well as cost and resource use, feasibility, and acceptability, must also be considered when formulating the recommendation. For this, view the next video in our series about making recommendations using the evidence to decision framework. In conclusion, guideline developers require succinct and transparent evidence summaries to support their decisions. The GRADE evidence profile contains detailed information about the body of evidence for patient-important outcomes relevant to a specific healthcare question, the assessment of the judgments about the underlying quality of evidence, and the summary of findings represented by the key statistical results from the systematic review. The information in a completed evidence profile will be reviewed at the guideline panel meeting and will be used to inform the recommendations made by the panel. The evidence profile is also included in the final guideline publication to transparently share with the users of the guideline the evidence that was used to support the panel's recommendations. You can also find more information to learn about the GRADE evidence profile in publications from the GRADE Working Group website and any suggested articles. This concludes our video about the GRADE evidence profile and how it is used in guideline development. Thank you for watching.